Welcome to this virtual webinar, World Patient Safety Day 2025, Safe Care for All Newborns and Old Children, organized by PAHO. I'm Pablo Duran. I'm the Regional Counselor for Perinatal Counselor of PAHO. I'm be the moderator in this very important activity. Before starting, I would like to remind you that throughout the whole session, we'll have simultaneous interpretation in English, Spanish, and Portuguese. You please feel free to choose the language you prefer by clicking on the interpretation icon on the bottom of your Zoom screen. You have a little globe.
Before we begin, I would like to remind you that simultaneous interpretation is available in English, Spanish, and Portuguese throughout the session. You can select your preferred language by clicking on the interpretation icon at the bottom of your Zoom screen. Para dar entonces inicio
to launch formally this event, I have the pleasure of inviting Dr. Ernesto Bascolo, Unit Chief of Primary Health and Comprehensive Services Delivery at PAHO. The WHO also is going to give some opening remarks on behalf of the Director of System and Health Services Director, Mr. Fitzgerald. Thank you very much for this opportunity. As you know, today we celebrate the World Patient Safety Day, as we do every year, but this time under the theme patient safety from the start. This is the message, which reflects a very deep truth that safety is not only a privilege, an expectation far away, but it needs to be considered as a fundamental human right, an essential condition to move forward towards universal health. Today, we are gathered here to not only reflect, but also to renew our commitment with one of the most important principles of public health care, to protect life from the very beginning and to make sure that we have a safety environment respectful for those who need it the most. Every pregnancy, intervention, childbirth, newborns, every children, every child, girl, men, teenagers need to receive healthcare free of any risks, any preventable risks, no matter where they are born or no matter the social conditions of their families. In our America region, we have made a lot of progress regarding public health policies aimed at primary health care. However, there are still many inequalities that generate differences or gaps between those who can access safe and quality healthcare and those who still face different types of obstacles: geographical, economical, cultural, organizational gaps. Reducing these gaps, these inequalities to access healthcare services is a priority, indispensable priority. Patient safety from the very beginning of life is a measure of social justice, an indicator of quality, of health quality. Primary healthcare is still our fundamental strategy, our guideline, our transformation agenda of healthcare systems. Here we are going to build the first intervention lines of diagnosis, safe healthcare, and where the services are the closest to communities and families. When I say closest, I mean from a geographical point of view, but also from the relationship. It means the relationship between populations and services. This relationship needs to be primary healthcare. In this framework, we need to strengthen patient safety at all healthcare levels. This is key to assure the continuity of the care, the integrity, the trust of healthcare services systems. At the same time, as we're going to see in this webinar, we need to adopt a lifetime approach for patient safety. Healthcare does not begin at the birth, but it's a prenatal element that continues with prenatal care, the care for the newborn as well, and throughout the teenage years. During these stages, we have it's a sequence, but they are all interconnected and they are affected by common determinants. And one of the most important topics for our approach is that they have sustainable impacts throughout the whole life. This is why protecting safety from the very beginning means investing in health, in development of societies that are not only healthier, but more resilient. I would like to highlight also the important role, the key role of healthcare professionals, of human resources, of professionals, of technicians, of community agents, with dedication, with a lot of commitment. They transform every intervention, every protocol into concrete care on a daily basis. Their work allows to save life. The role of human resources is key, and that's why we need to keep on investing on their training and ongoing training on the well-being of human resources, of healthcare teams, on their capacity to work in safe environments. These factors are essential elements of any strategy regarding patient safety. I would also like to highlight a concept that is very important: innovation. Innovation is key in our agenda. In this case, I want to include technical or digital technologies, in artificial intelligence, solutions based on evidence that allow for or allow to build, to have tools that help reduce any mistakes, any errors, thus preventing risks and being able to reach timely diagnoses. When we talk about innovation, we're not only talking about the application of technologies transformed into management tools, diagnosis tools, therapeutical tools. We're also talking, when we talk about innovation, we're talking about new ways of organizing. We're talking about the possibility of rethinking, and if we're talking about the practice, new healthcare models based on the person with another pillars of healthcare, primary healthcare mechanism of social participation that reinforce something that is so important. I mean, trust, the trust in healthcare systems. This is the relationship between healthcare systems and populations. This effort needs for an active participation of every single actor. I mean, all the decision makers, managers, healthcare teams, as I said, professional associations, scientific associations, and also civil society, families. A very big important part of this conversation is also concerns what we want to build with this webinar. In 2025, we define at PAHO very clear objectives, very shared objectives among all these actors. Improving safety in medication, strengthening diagnostic safety through telemedicine and through electronic or digital clinical history, reducing risks to all newborns, principally premature birth and those who have diseases when at the time of birth, strengthening prevention and control of infections, and to promote active commitment of users, men, caregivers, in every stage of the healthcare process. In every stage of the healthcare process. The Americas face realities, as you know, that are very different, very diverse, but we have a common challenge to build healthcare systems that are more resilient, more safe, and based on the person. The commitment from countries, professionals, civil society is decisive to make this aspiration into concrete results that are perceived by the population. Today, we reaffirm that the quality and the safety of patients are not a destination, but a pathway to improve, to a pathway of improvement processes. And in this path, nobody needs to be neglected. We need to, everybody needs to have access to safe healthcare. Everybody needs to be part of this process. PAHO conveys governments, institutions, healthcare professionals, communities, families to join efforts to prevent any harm, to consolidate a safety culture, and to make sure that in every single part of our region, every child has the opportunity of growing healthy in a safe environment from the very first day of their lives. Thank you very much, Pablo.
Muchas gracias, Ernesto.
Thank you, Ernesto, for these opening remarks, very inspiring, that laid the foundation for the presentation for the experiences that we're going to be sharing throughout this webinar.
Sigue este seminario. A continuación, entonces, atenderemos a dos presentaciones.
We're going to have two presentations now that will highlight the framework. I'm going to share my screen.
Que van a resaltar el marco y la relevancia
that will highlight the
de
framework, the relevance of approaching safety, the patient safety, the healthcare of newborns, women, girls, men, following what Dr. Vascolo just said. We're going to listen first to Dr. Café, who is the Chief of Health Life Unit in the Department of Health Systems at PAHO. She's going to cover the challenges on safety and health care of newborns newborns and children. She'll be presenting with Dr. Susan Cerrulla, Unit Chief of Women's Maternal, Neonatal, and Reproductive Health Unit. Dr. Ernesto Bascolo, Unit Chief of Primary Healthcare and Integrated Service Delivery, is going to cover patient safety from the very beginning. With this brief introduction, we are going to now give the floor to Dr. Café.
Thank you very much. Good morning, everybody. Buenos dias. Goedemorgen. That's the end of my languages. And so it's really a pleasure to be able to share this presentation this morning that we developed together with Dr. Susana Cerrulla. Thank you, Dr. Bascolo, for your words, because you made my life a lot easier, because I'm going to reiterate many of the messages you already gave. So could we go to the next slide, please? So in this presentation, we're going to highlight some issues that will serve as the basis for further discussion, and starting with some of the data that should alarm all of us when we speak about care and survival of children and adolescents. One is that in our region, we have around 1 million premature births every year and 100,000 neonatal deaths. That translates into more than 200 every day. And of course, we also have the high numbers of fetal deaths, of which almost 20%, 1 in 5, happen intrapartum. And then many of these causes of neonatal death or fetal death are things that we could avoid or reduce with proper action. The same goes for mortality, postnatal mortality in children younger than 5 years. In our region, we have advanced in the reduction of preventable child mortality, but we still have more. We still have sufficient numbers of preventable deaths in children to concern all of us, no? And some of these deaths are due to congenital anomalies, diarrhea, pneumonia, all these infections and causes that are things that are treatable and preventable. And so when we look at this data, we realize that we still have a lot of work to do in our region. Next slide, please. Both on global level and regional level, we have very clear targets. We know that in the Sustainable Development Goals, some of the targets related to good health, SDG 3, focus on reduction of preventable mortality and morbidity in all ages, and specifically in children and adolescents. And that was translated into the global strategy for the health of women, children, and adolescents. I'm sure we are all familiar with the 3 keywords: survive, thrive, and transform. So survive refers to preventable mortality, and thrive refers to going beyond preventable mortality to ensure that all our children, women, and adolescents have an opportunity to develop to their full potential. And then, of course, on regional level, we have a very concrete commitment, the plan of action for the health of women, children, and adolescents, which is really a regional translation of the global goals. And this plan of action was adopted by PAHO member states in 2018. So it's a shared commitment in our region. Next one. We also have sufficient information on what to do. We have global guidelines, we have regional guidelines, and also operational programmatic guidance on how to ensure that our children not only survive, but that they thrive, and how to create an environment that allows them, that facilitates their life and well-being, which is the third word of transform. Next one. We also, and Dr. Bascolo mentioned it, we also have tools that maximize the digital innovation. We can mention here the app that makes it easy to access information on neonatal health, information related to breastfeeding, related to caring of the baby. And we also have there are other tools that digital tools and platforms such as the PAHO virtual campus that really provide opportunity for learning and to put into practice what we have learned. Next one. But what we all need to keep in mind is that children and adolescents are not small adults. Sometimes we have these generic practices and SOPs, and we think they apply to everybody. But the most important thing that we need to keep in mind, and that I think that this celebration of patient safety with a focus on children and adolescents reminds us that children need specific interventions. They need personalized and individualized care that responds to their phase of life. Dr. Bascolo mentioned the importance of a life course approach. In every phase of life, there are different needs that we need to keep in mind and that we need to respond to be able to provide the optimum protection and support. When we think about their physical development and the fragility from birth, and as they grow up, their evolving cognitive capacity, the social context that is so important for growth and development of children, we realize that they need special attention that they sometimes do not get, and that sometimes contributes to medical problems or even to death. Next one, please. And so when we want to elaborate on the theme of patient safety, we need to take this into account, that children and adolescents have special vulnerabilities, and that safety is not an option. It is a fundamental principle. It is a right of these children that when they enter into a care environment, that they are protected and that they are safe. Next one, please. And that is a responsibility of all of us. And again, Dr. Bascolo mentioned that it's a shared responsibility to ensure that they are safe in the care environment. We know some of the main causes of problems, not in the care environment, that reduce patient safety, and these include, and I'm mentioning a few, I'm sure you will hear more during the webinar, but these include errors with medication, calculation of medication, of doses, but also errors with the diagnostics. Infections associated with the care, infections that are picked up in the care environment, difficulties with the availability of proper technology, and especially when we think about premature babies, the technology they need, the medical resources that are necessary, that will help preserve their lives. And of course, lack of alert systems that say, hey, here is a problem. We need to take action. When something happens with one baby and then the next baby and then the next baby, it means that there is a problem that needs to be addressed. Sometimes these early alarm systems are not operating properly. Next slide, please. And so when we speak about improving patient safety for children and adolescents, and we're hoping that you will all commit to doing more to reach that target as we move forward. It's, as we mentioned, this is a responsibility that we all share. The family, the healthcare system, individually and as healthcare providers and as a team, we all need to be committed to provide optimal safety to children and adolescents in a care environment. Next one, please. And to close, I'm going to mention a few of the things that can be done, the norms to improve the quality. And I'm not going to elaborate on that because I'm sure these things will come back as we proceed with the webinar. But first of all, we need to ensure that all the practices, the SOPs, the protocols are based on evidence. And as mentioned, this evidence exists. We have all the tools, we have all the data, and so we really have no excuse. We have to make sure that we have information systems that generate the data that is necessary to take proper action, to take timely action. We need to have proper systems for referral and counter referral so that the children in care are guaranteed continuity. And we also need to ensure that there's effective communication between healthcare providers with families, healthcare providers with other sectors that need to be part of this environment that supports our children. Next one. To continue, we need to ensure and we need to always keep it in mind that safety it's a right. No, it has to do with recognizing the human value and the dignity of everybody, regardless of their age, including our children. Make sure that there is respectful care and that there is proper protection. We also need to ensure that there is an environment where psychosocial care is provided, because we know that many times the level of care depends on the environment that is needed to support parents and to support children and adolescents for family health. Ensuring that we have properly trained and motivated human resources who see the value of every human life. And then, of course, the whole issue of physical resources, ensuring that there are enough resources, including equipment, medicines, everything that is needed to provide quality care for children and adolescents. And I think I'm going to stop here. Next one, please. Thank you very much. And again, I see Dutch is missing, so dank u wel. Thank you very much. Merci, obrigado, for your attention and for this opportunity to present this brief presentation. Thank you, Pablo. Back to you.
Muchas gracias, Sonia, por la excelente
Thank you so much.
presentación.
Thank you for the excellent presentation. And now I will give the floor to Mr. Ernesto Vascolo, who now will talk about the safety of patients since the very beginning. Thank you so much. Thank you so much, Pablo. I will try to not to bore you a lot, but I'm going to try to summarize some messages that I think can complement the presentation, the first presentation that I did, and basically the excellent presentation made by Sonia. The main goal, my main goal, is to try to link the patient security agenda, and as we have repeated since the very beginning, and when I say since the very beginning, I mean not just the recently born, but all the process, all the care process, with a perspective of primary attention and a perspective of course of life. And what I want to highlight now is how we can interpret this agenda as part of a transforming agenda of the health systems, not just with a specific agenda as an agenda that only lies on the individual commitment of professionals and patients or families or users, but I would like this to be interpreted as part of a structured agenda for strengthening the health service system. With this purpose in mind, first, I would like to mention that when we talk about patient security, we are focusing on one of the dimensions, that is quality. And this is one of the ways, and I think it's one of the most important ways on how we interpret the performance, the output of the health services systems. And as you know, when we analyze the performance of the health systems, we need to interpret what are the functions of the health systems and how to assess these health system functions, and not just analyzing each of the functions separately, but as a whole. And when I say the functions of the health system, I am referring to governance. And of course, when we mention governance, it's not just about health policies, not only regulation frameworks, but the different governance structure that in a certain way will design the architecture of the health system. The function of the health system depends on the structure, on this architecture, and many times these governance structures are referred to or are responsible not just for the quality, but also for a safety, a security patient agenda. Therefore, it's not just an individual responsibility in main condition, but also how we try this agenda to be included and deeply included in the different governance of the health system. Secondly, I want to highlight something that Sonia has already explained very good, that part of this agenda of patient safety require resources. And when I say resources, not just human resources, but also infrastructure, technological resources, quality conditions from a structural point of view. This is one of the components of the health system functions that are very important, that even have an intersectoral perspective that is related to generating the critical resources of the system. We cannot think in an agenda, in a patient safety agenda, without taking into account or including this component. Third, the component of funding. When I say funding, I'm not thinking just about that the health system shall have the resources required, but also to have the resources organized and assigned according to the needs of the population and the quality conditions of the services that we need to promote. And finally, and I really believe that this is one of the main important points of the functions of our health system, that is the supplying or provision of services, governance, funding, generation of resources, they have a reason to be because they facilitate our delivery to render the services. And here I have some of the points that initially mentioned, and Sonia reinforced my idea. And this is this conception of course of life that in a certain way shall modulate our healthcare service, focusing on the patient and on the people. Nothing is more important than them, than including this perspective when we are talking about the recently born, when the delicate conditions of life of this recently born baby and the whole familiar environment are critical. And in addition, as other important elements in the course of life, each step we take in this space, in this stage of the life, will have an impact in the whole course of life of the person and of our society. A second big topic I want to highlight, or maybe reinforce, that when we talk about quality, we are talking about the output, the results, and in general, this links the quality with access. We cannot think on quality issues without an integral access, without an access to the main service, the suite of service that our population requires, and our analytical approach that motivate or found the health interventions is that we need to think on the aspect of access and quality crossing by efficiency and equity criteria. I mean, when we say that our services shall be with high quality, warranting the security of the patient, applying quality regulations, we mean that efficient interventions provided under those conditions. And also I need to reinforce our commitment on those populations that really needs more. That's why equity, equality is crossing, it articulate us regarding the focusing of this policy. I want to not to be too repeating, but these are pillars of our strategy of primary health care. And finally, this is not just a statement, this is not just declared, it is necessary to be aware, as Sonia mentioned previously, in the challenge we face, that we need to, in a certain way, to add forces, add commitments. We need to have an agenda, not just for moving on and progress for the universal health. We need to have important institutional transformation. It means that aspects that are the regulatory framework, for example, the regulations, the formal rules of play of the system. When I say regulation, it's what we can do or we cannot do within this health system and how to do it. We mean institutional changes when we highlight certain values, as obviously the universal health. But in addition of all of this, when we talk about transformations, we need to mention cultural transformation, cognitive transformation. And obviously, when we talk about patient safety, if there is a core point that we want to highlight, is the construction of a culture of patient safety. And nothing more linked to this culture than this conception of primary care service that are not just limited interventions, but a way to rethink, redesign, and retransform our health system with the logic of what are the needs of our population and the perception. Thank you so much again for this opportunity. And this is really an interesting webinar, not just because of the speakers, but also because of the more than 1,000 people connected, just join us, and their active participation in the chat. Thank you so much, Ernesto. Thank you for your excellent presentation. A presentation that, together with Sonia's presentation, highlight the need to deal, to work, to promote on safety, and the importance of this at the starting of life. The presentations highlight the safety as an aspect to take into account first, always and in all environments, and that each newborn girl or boy, they are not small adults, but requires a safety and individual care. But we are also aware that in the Americas region, there are experienced and successful perspective. That's why now we would like to invite a panel where we are going to share some of these experiences that will help us to reflect and trigger actions in each country, in each jurisdiction, in each organization. That's why we're going to give now the floor to a second time of this webinar, where we are going to have 5 experience. We are going first to listen to Aline Henneman. She is nurse expert in child mother health. Aline is magister in children health coordination on health service of children, adult, teenagers, and young from the Department of Comprehensive Care of the Ministry of Health on Brazil. Then Paola Barrientes, que is National Consultant of OPS. She will talk about the importance of improvement diagnosis. She is a bachelor's in nurse, expert in obstetrics. Then Alejandro Dinersten, neonatologic doctor, to prevent recently born blinding. He will talk about the reduction of risk of recently born prematures and the experience of the group of rock in Argentina. Marlon Timothy from Trinidad and Tobago. He's going to talk about the prevention of infections. Marlon is neonatologist, graduated from the Western University and with a fellowship in perinatal medicine from the University of Toronto. And he is head of the neonatal office of his country. And finally, we will have in this panel the presentation of Cara Gilarda, the March of Time, United States, who is going to talk about the involving of parents and caregivers for improving the quality and safety of the patient. Cara Gilardi is Associate Vice President of NICU Initiatives, Mark of Knives. She leads the NICU family supports across 70 hospitals. March of Dimes, she works on March of Dimes since 1994, held in key roles. And March of Dimes, it's a non-public stakeholders and leader in advocacy and prematurity and the consequence. So now we will give the floor to this excellent panel. And first, we will give the floor to Aline for her presentation. Thank you so much.
Bom dia a todos. Em primeiro lugar, Dr. Pablo.
Good morning, everyone. Dr. Pablo, thank you for the invite. Representing the Ministry of Health, I just wanted to make a correction. I'm a technical nurse of a children and adolescents in the comprehensive department of the Ministry of Health that is coordinated by Sonia Venancio, Dr. Sonia Venancio, who is here. I'm going to share my presentation. And let me know if my presentation is okay. If you can see my presentation.
Então, mais uma vez, bom dia, trazendo pouquinho
Once
sobre a
again, good
experiência no
morning.
Brasil na liderança
I'm
da
bringing a
nossa
little
agenda
bit
de
of
emergência.
the
Então, fiquei muito
experience of
honrada por
Brazil.
estar nesse
I'm honored
momento
to
hoje,
be
como já disse
here
anteriormente,
today, as
representando o
I said
Ministério da
before,
Saúde, e
representing the
também
Ministry
muito
of Health.
honrada por estar
And I'm
aí,
also honored for being
quem me
here.
antecedeu as falas, né, a doutora Sônia, a doutora Ernesto, que trouxeram
And
muita
for all the
informação
messages
sobre
that
esse
Dr.
ano, cuidar da
Ernesto
saúde mental do
said,
recém-nascido e toda criança, e aí trazendo
for
desde o início
newborns,
do ano, pensando
adolescents,
nas questões
from the very
relacionadas à
beginning
medicação, né, que a
of
medicação, na verdade, ela
life.
deve
And when we
salvar
mention
vidas e não
medications,
colocar em
medication
risco.
should
Erros
save
de
lives
medicação,
and not
né,
put them
que
at
são
risk.
uma das causas
Medication
evitáveis dos
errors
danos.
are one of
Então,
the
como que a
leading
gente deve
causes of
trabalhar com
preventable
isso no
harm,
nosso
and
dia a
we should
dia,
work
e a
on this on
prevenção
a daily
fortalecendo
basis,
aí a
and also we
segurança do
need to
paciente.
prevent
Então, quando a gente pensa
and
nesse
strengthen
cuidado
patient
seguro para o
safety. Once we
recém-nascido e
have
para a
this
criança desde o
safe
início,
care from
eu
the
gostei
very
muito da
beginning,
fala da doutora Sônia, quando
I
ela
really
traz
liked
também a
when Dr.
gestante, né?
Sonia
Então, a gente
mentioned
começa a cuidar desse
pregnant
recém-nascido, a
women.
gente
Everything
começa a
starts
cuidar dessa
there,
criança
and that's when we
desde o
should
momento
be
da
taking care
gestação.
of
Os
children from
objetivos
the moment of
da campanha
pregnancy.
esse ano, então, trazidas pela
The
Organização
aims
Mundial
or
de
the
Saúde, são
objectives
conscientizar
in
sobre
this
os riscos
year
dos erros de
were raising
medicação,
awareness about the risks
engajar
of medication
profissionais de
errors, and
saúde e a
engage
sociedade,
professionals,
promover
managers, and
medidas
society,
práticas de
promote
prevenção e
practical
também
prevention
garantir o
measures,
direito ao
and
cuidado
ensure
seguro.
the right to
Quando a
safe
gente
care.
pensa, né, nesses
When we think
objetivos, a
about
gente
these
entende que o
objectives,
trabalho
we
ele tem que ser um
understand that
trabalho
the work we
intersetorial.
do
Não
is
adianta apenas a
intersectoral.
saúde estar
It doesn't
envolvida,
matter.
como bem
It's
disse o
not
doutor
only
Ernesto,
health
mas
or what
outros
we
setores também
have,
estarem
but we need
envolvidos nesse
to
processo de
interconnect the
cuidado
different
para que a
sectors
gente possa garantir
in this
realmente uma
regard,
qualidade
so
nessa
we have
assistência e, por fim, a
quality,
segurança
and at
que
the
nos
end
traz
we
aqui
will
no dia
have
de
this
hoje.
safety we need.
Os erros, então, né, pensando que a gente tem no
These
Brasil, os
errors,
erros nas
when
crianças
we
e nos
think about
neonatos, que
newborns
são
and
aí
children,
uma população, como bem disse a doutora Sônia, com uma
as Dr.
maior
Sonia mentioned,
vulnerabilidade, eles
they
estão
have
muito
the greater
relacionados a
vulnerability is
doses por
linked
peso,
to
cálculos complexos
doses
e uma
by weight, complex
farmacocinética
calculation,
variável.
and
Então, quando que a
variable
gente precisa olhar para a criança,
pharmacokinetic.
olhar para o
When
neonato,
we
não
see
como um
newborns
adulto,
and
mas como
children
um
not as
indivíduo, um
small
sujeito de
adults,
direito e que
but as
precisa, por
subjects
si,
of
ter
right,
um olhar
who should
individualizado,
be
singular para o seu
focused as
cuidado.
individuals.
Olhando para as taxas do
When
Brasil,
we
nós temos um
see
estudo
the
que mostra que
Brazilian rate, the
43,5% das
studying
prescrições
neonatal
apresentam pelo menos
ICU,
um erro. E quando a gente
43.5%
olha
of
a
prescriptions with
incidência
at least
disso,
one
a
error. And
gente
when we
tem
realize
os
this,
erros relacionados a
we can see
prescrições e
errors that
principalmente
are
aos
related to
cálculos de
prescriptions
dose.
and
Então, mais uma
dose
vez,
calculation.
corroborando com a
Once
fala
again, when
da doutora
corroborating
Sônia, nós temos que
with
olhar
what
para essa
Dr.
criança,
Sonia
para
mentioned,
esse neonato
we
como
need
um
to focus
sujeito e não
on
como um
newborns as a
complemento.
subject
E fazendo uma
and
comparação com
not
dados
as a
internacionais, a
newborn.
gente tem de
And
4 a
when we compare
35
this with
erros por
international
1000
data,
dias de pacientes.
4
Então,
out
é um
of
grande
35
desafio a gente
errors per
conseguir
1,000 patient
reduzir
days.
os danos
So
causados
we need
pelos
to
erros de
reduce all this
medicação
damage
em
caused by
crianças
medication
e
errors in
neonatos, e para isso a gente
children,
precisa realmente
newborns, and for
qualificar cada
this
vez
we
mais
need
as
to
equipes que estão à
verify
frente
the
desse
equipment,
processo
the
do
teams
cuidado.
that are
Os erros de
behind
doses
these
são os mais
errors.
frequentes,
Dosage
então, como eu
errors
já
are
falei
the most frequent,
anteriormente.
as I
Como é que
mentioned
o Brasil
before.
responde a essa nossa
How is
necessidade de
Brazil responded
qualificar e
to this
melhorar a
need
segurança do
to
paciente?
improve
Então,
the
em
safety of
2003,
patients?
o
In
Ministério da Saúde
2013, the
lança a
Ministry of
Portaria
Health
529, que traz o Programa
uh,
Nacional de
launched
Segurança
an
do
ordinance
Paciente,
number
que tem por
529.
objetivo
The
reduzir
objectives
riscos e
of this
danos,
ordinance was to
implementar
reduce risk
protocolos de
and harm
segurança
associated
e
with
estimular a
healthcare,
cultura de
implement security
notificação e
protocols in
melhoria contínua
institutions,
do processo do
encourage a
cuidado.
culture of
E quando
reporting
eu
and
trago
continuous
cultura de
improvement.
notificação, a
And
palavra
when they
cultura já
brought
nos
this
traz um novo
culture,
desafio. Porque
it
quando a gente
was or
envolve
presented a new
cultura, a gente
challenge.
sabe que o
When we say
processo,
culture,
muitas
we know
vezes,
that the
ele é
process
muito
many
mais
times
demorado. A
is
gente precisa de
delayed because we need more time, we need more resiliency so this process happens, continuous health education to reach these goals. And the main access for safety are basic protocols, and I'm bringing some examples here. Identification of the patient. When I talked about identification of medications, I also like to bring medication prescribed. So when we talk about all these devices that are bringing differences and these connections to warranty or ensure more safety, not only for patients or for professionals of health, and all that has to do with a safe surgeries and with simple questions. For example, when we create patient safety centers in hospitals and health services are very important for a not only at a hospital level but also primary care. And by bringing a little bit of what Dr. Ernesto mentioned, monitoring through Notivisa and national report, it's important to mention this because the newborns are going to the hospitals that they can go back to their houses. The primary care and hospital care is very important so we can make the transition of this child so the hospital care can put it back in their houses. As I mentioned before, this monitoring through NOTIVIS and national report, since 2013, we've been working in this program for patients that is providing care of all the people in these areas. As Dr. Sonia mentioned, we need to look at children in a way, in an individual manner, in a different way, not as we see adults. That's why I'm bringing the national policy for comprehensive child health care. And this year, it's been 15 years, established by the Ministry of Health through Ordinance number 1130. Within this policy, we've been working on 7 axes, and this is about all the work we've been doing. And I'd like to focus on axis 1 that has to do with pregnancy, the birth of the newborn. We need to understand that the patient safety is a cross-cutting theme of all the different axes, looking at the child in all the different stages, thinking that the different stages uh, focus on different levels. But when we talk about safety in terms of medications, we need to remember that all that has to do with devices, dosages, every age, weight, different doses, different devices should be followed. So quality should be improved to ensure safety of our patients. And when we talk about Access 1, the Ministry of Health has brought these 10 steps of newborn care. These 10 steps were designed for all the newborns in all the country for ongoing care. I would like to bring the attention to step 7 and 8. 7, practice the kangaroo method and integrate the family and interprofessional team into individualized care. Why am I talking about this? When we talk about the family is part of the process, family should be considered part of everything. They are part of this care process and they should be guided so they can support the team in the care quality process. How are they going to do that when they go back to their houses? And I also like to mention, as I mentioned before, so they have a wide perspective so they can focus on the alert so the the children receive the proper care. Now, when we talk about step 8, follow the SES or guidelines for patient care with newborns. So this means that we need to focus on this protocol established within the different units so we have effective communication, adequate identification of the newborn, and how we can connect this process with better quality by remembering that this process is ensuring the patient safety and not forgetting the family. And when this newborn has anything or something happens to the newborn, there should be a map of what is happening to the baby. Many times, parents or relatives, the ones that are the closest with the babies, are not the closest relatives. There are some other people, such as friends as well, that are supporting this care process. By following all this and
thinking of what Dr. Ernesto mentioned, in Brazil, we need to look at things that are related to ethnical and race areas. There was a publication of children network with the name of Aline Pimentel. We have this publication that has to do with the Aline network. This is a support network that we used in Brazil, Rede Aline, where we are bringing all that has to do with a anti-racist strategy for health, reaffirming the Ministry of Health's commitment to tackling historical challenges. A low-income Black woman living in Belfort Roxo in the Baixada Fluminense region. She died in 2002 at the age of 28, 6 months pregnant, leaving behind her 5-year-old daughter, Alice. The Aline case was the recognition that maternal death from preventable causes constitutes a violation of women's human rights. Brazil is bringing this case, is reflecting on this case, and from this case, we are reaffirming the Ministry of Health's commitment to tackling historical challenges, as I said before. This network is bringing a perspective for children care, and we have this wide perspective for pregnancy care and also other questions for prevention and all the different perspectives that are related to the birth. And I'm bringing a little bit here, something that is strengthening patient care. We need to have more investment. We are starting with investment with the increase of postpartum period and child health. There is a value of 20% of daily rate in bed costs. In Brazil, the bed costs are intermediate costs between intensive care, and this is the unit, the kangaroo unit we have, and we are making this interface from thinking about the progressive care areas. Why are we thinking about these progressive areas and thinking about the quality and safety of patients when patients don't need to be within the intensive therapy or neonatal areas where we have more technology? These babies could have care with the same areas related to science or care with more or less technology, and all these care ones for intermediate care or kangaroo areas, we can bring this level technology with all these strategies, kangaroo, and with this we can foresee, we can also focus on contact with their mothers, and we can continue participate
on this care process to improve all the bed costs. We need more investments so this happens. In Brazil, through all these new ordinances, we are improving this investment of intermediate units by showing how much we understand the importance of this care. So that means that in U5 and U5, 300 reais. Now the daily rate is 210, and according to bed qualification incentive, we are focusing a lot on this care, and the teams are supporting these care areas, and they have increased in 70%. Apart from this, we also have this follow-up outpatient care, outpatient clinic. From now onwards, we have this component, and it has been increased monthly cost for each new service. And we know that this is going to help us in care process for postpartum period and child health. Also, there has been an expansion and collection of human milk in all the BLH. It's been said that human milk is the best that they can receive, and that's why we have also improved these areas. Many times, babies don't need to any therapies, and that's why we're bringing all these human milk programs, and also this new component of the network. All these human milk banks have received 20,000 reais per month
Aline,
if they are
Aline,
self-sufficient
você
banks.
consegue me escutar? Doutora Suzane, você tem mais um minuto,
Apologies, Aline,
porque
you just have one
cinco
more minute.
apresentações
There are
muito
5
rapidinho.
presentations. Apologies.
Muito obrigada.
Thank you.
Os autossuficientes, então, aonde eles atendem 80%
Now,
das prestações das unidades
as I
neonatais
mentioned
e
before,
15 mil mês
the
aqueles que
expansion
não
of collection of
atendem.
human milk
Passando
has been
rapidamente para a
increased,
estratégia Corinel e
20,000
método Canguru,
per month and
medidas na atenção hospitalar, então, que
15,000
já
per
foram
month.
faladas, que eu não preciso
Okay,
me deter mais quanto a
I'm
isso.
going to stop in this part
Na
on
atenção
the
primária,
primary
muito
care
bem faladas,
measures.
então, também pelo Dr. Ernesto.
Dr.
E aí,
Ernesto has
trazendo as
also
metas da
mentioned this part.
ODS, que
And
todos
now
nós
when we talk
trabalhamos
about
juntos para alcançar, acabar com as mortes
the
evitáveis e recém-nascidos
SDGs
menores de 5
targets
anos e acesso
and preventable
universal a
deaths of
medicamentos
newborn
seguros.
children under
Então,
5
através
years of
dos
age.
programas que eu apresentei do
Through
Brasil
all the
Bem, que a
programs I
gente busca.
mentioned, this is more or less what
Alguns
we're looking
desafios que
for. And
acredito
some
que muitos de
challenges
nós
I think
enfrentamos
that most
ainda,
of
e um
us
deles é
have
a
faced
falta, né?
before.
As falhas de
Some of
comunicação
them
entre
failures in
as
communication
equipes.
between
E aqui eu só
teams,
trago
lack of
uma mensagem
protocols and
final. Se
technologies, and I
mudarmos o
bring in
início
this
da história, nós mudamos
final
toda a
message. If
história.
we change the
Então, que
beginning
a
of
gente
the
possa
story,
ter
we
mais
change
momentos
the
como
entire
esse para
story.
compartilhar
We can spend
temas tão
more times
importantes como
like this,
segurança do
and this is
paciente,
very
para
important
que a gente
as
possa
the
garantir
patient's
futuro
care
melhor
and
para
safety,
todas
so
as
we can
nossas
ensure
crianças,
a
não só
better
no
future
Brasil,
for
mas
all
em
our
todo o mundo.
children in
Fico
Brazil
à
and all over
disposição
the
de todos e
world.
aqui está o
And I'm
nosso
here
e-mail
if
para
you
contatos. Muito
want
obrigada.
to ask any questions, and I'll be here. Thank
Muchas
you.
gracias, Aline, por la
Thank you very
presentación, por
much,
la
Aline, for your
excelente
presentation, your
experiencia
excellent
de Brasil y su
experience
política en torno a
in
su
Brazil, its
seguridad de los nacidos.
policies.
Y siguiendo entonces con la agenda, ahora damos la palabra
Now we
a
give the
Paola
floor to
Barrientos,
Paola
que desde
Barrientos
Honduras
from
nos va a
Honduras, who is
presentar la
going to
experiencia en
present
términos de la seguridad diagnóstica. Adelante, Paola.
patients' diagnosis safety in Honduras. Good morning. Good morning, Dr. Ernesto Bascolo, all the speakers, all the participants. Thank you very much for inviting me. So, patient safety World Day reminds us that safe care should start from the very beginning. It's a pleasure for me to be here to share the experience of PAHO in Honduras, in Intibupa, so this healthcare based on primary healthcare. Health Secretariat, with the technical and financial support of PAHO Honduras and the regional advisor on perinatal health, has been leader on strategic interventions to reinforce patient safety, neonatal safety, focuses on two essential keys: improving the conditions and daily conditions for healthcare during birth, ensuring safe environments and standardized protocols for newborns, strengthening competencies for health personnel. This has shown how we can generate sustainable changes on neonatal care. I'm going to share today the experience in the health region of Intibucá, a department with a population of about 278,000 inhabitants. Every year, we register 6,400 new births, more or less. We need to highlight that 78% of population live in rural areas and belong to Leica's population, one of the 9 autochthonous peoples that are recognized in Honduras. Based on the results, we carry out in this region, in this health region, an analysis to identify the improvement opportunities, to propose strategies, and to define management process that can be implemented by authorities and technical staff. We elaborated an comprehensive tool that will allow us to measure enabling environments, 44 criteria, conditions to neonatal transfer, 6 criteria, compliance with national regulations, 15 criteria, staff training, 11 criteria, through a analysis methodology based on strengthening on an ongoing basis the quality to ensure neonatal patient safety. As you can see in this chart, the baseline shows that the dimension with the lowest percentage, 48%, concerns the staff training, health staff training in comprehensive care of newborns. This was a key opportunity to strengthen neonatal patients' safety. We implemented these models, these training models, based on evidence, helping babies to breathe, essential care for all newborns, essential care for small babies, a methodology of low doses, high frequency with an ongoing clinical mentorship with practices. We trained 47 providers in different models. 100% of child maternal services have trained staff and 2 certified mentors in the main hospital, reference hospital in Intibucá.
Perdón, Paola,
Paola, could you slow down, please, for the translators? Thank you. In this part, I would like to share with you the main innovations, methodological innovations in the implementation of patient safety, neonatal patient. Virtual mentorship. We established a telephone monitoring system by the mentors to ensure the continuing of learning post-training learning. We strengthen the capacities of healthcare personnel. The reanimation corners. We created spaces of simulation on a weekly basis designed to strengthen skills of our staff through practical scenarios and the systematic evaluation of skills, ensuring this way the continuous improvement of neonatal care and the system of lighting for quality and safety of the prenatal patient. This was a visual tool to help the teams identify the priority areas of necessary interventions and to recognize what the strengths are using different colors, very clear and very easy to interpret colors. These innovations are transforming the way in which we can guarantee the quality of the healthcare to newborns. These actions have a direct impact on safety and quality of health of neonatal healthcare, strengthening clinical procedures such as selective aspiration of newborn, early maternal breastfeeding, blood sampling. The reference hospital in Intibucá trained 100% of their staff on essential neonatal care, 100% of compliance with neonatal reanimation regulations and system of neonatal transfer operational 24/7 with trained staff. 100% of maternal healthcare services of the first level increased their capacity regarding neonatal care and emergency care, standardizing stabilization, pre-transfer protocols, and strengthening the communication with reference hospitals. The participants are committed to replicate these actions to train their own personnel, their own staff. There's a shared use of tools between teams and the ongoing mentorship to the post-training follow-up. There's a very high institutional commitment regarding active participation of national and local authorities. And the neonatal patient safety is not essential, it's not optional, it's key to guarantee the universal access and coverage, ensuring the right to life and the universal health of every newborn. We can continue with the other presentation, then we'll see if we have time for the video. Is it okay? Sure, thank you. Thank you for sharing the Honduras experience. And now we have the presentation of Alejandro Dinerstein. The presentation on prevention of retinopathy. We cannot hear you, Alejandro. Can you hear me now? Yes. Thank you very much to PAHO, Pablo, for allowing me to present the experience of the ROP group in Argentina. For more than 20 years now, we've been working on the prevention of retinopathy. Could you choose the presentation mode? What, and now?
Ahora sí. Bien. ¿Qué es el grupo ROP?
What is the ROP group? We are a work model, a collaborative model. It's a multicentric ad honorem group that assures technical counseling to the bodies of the Ministry of Health. We receive information from 114 services in the 24 provinces of Argentina. We have national coverage. They provide data in real time, and we provide technical support, specialized support. We focus on institutions whose data is above the national average.
This also reports the data, analyze the data, and submit or send a suggestion to improve quality if possible. We have developed networks of diagnosis, on-site medicine networks. The group has support to buy high complexity equipment like laser, others. So in order to better support for the distribution or the equipments to buy, in addition to the and it has also established has said to establish a service care standards in order to reduce the gaps in the quality of service. So the rhinopathy, it's a critical challenge for the safety of patients. Why? Because it's a result of systemic failures in the service process, non-proper monitorization of the oxygen, lack of protocols, and deficient management of risk. It's a condition that can be avoided if we improve the care of the neonatal care and we make a proper monitoring. Most of the ROP cases can be prevented. And also it is important to mention that as the ROP is a quality of attention to decrease the incidence of ROP implies to reduce the incidence of the other neonatal comorbidities. So it's an obligation and a right of the patients. What are the strategies that should be synergics that we have implemented to prevent these pathologies? Obviously, the regionalization. Without the regionalization, it's not possible to have the results expected. So we need to have complexity centers to monitor the high-risk pregnancies and also neonatal, because the derivation after birth expose these patients to many risks. So the mother should be treated, and so the recently born, the pregnant women will receive quality service, and this is very important to prevent ROP, and they are going to be cared for by professionals very well trained continuously with state-of-art technology for dealing with this population, but not only a state-of-art technology, but also a proper maintenance of all the inputs and equipment. Institutions that facilitate integration of families to have individual attention of their children. And also, once we have a regionalization, we need to make sure we have a proper use of oxygen through strict protocols and continuous monitoring to guarantee that the oxygen saturation recommendations are followed. Another important is the nutrition and breastfeeding. So a proper support since the birth, it's very important. The breastfeeding and quality care, it's another prevention strategy. Within risk factors that our patients are exposed to is the anemia and the transfusion, where we are replacing fetal hemoglobin with adult hemoglobin that increases the risk of ROP. And so the late cutting of the umbilical cord, the protocols of restrictive transfusion, and second opinion strategy are factors that will lead us to reduce this risk factor. And of course, once we talk about all of the factors for primary attention, we need to have a proper diagnosis and the treatment. The treatment in situ is the best option. So, I mean, the place where the patient is placed to cover the diagnosis and the treatment. What are the results of the last year? 30% of recently born lower 1,005 grams have 30% of ROP. 9% of the premature baby require treatment. And here we have an important problem. Unusual cases, those patients that should not have a ROP because they are older, they have a higher increase at birth, higher weight at birth, they are still a problem. We have been able to reduce from 40% in 2003, 2004, and we have reduced to 12%, but this is still an ongoing task. Within the areas where we have just 3 opportunities loss of treatment, grade 4, we have strengthened the capacity of the professionals, ophthalmologic and neonatologic nurses. We have created networks for the attention and treatment, but also telemedicine medicine that allows to share image for diagnosis, for consultation, and within the achievements, we have the virtual course, training course that was available for many years that has allowed to train plus more than 2,000 professionals in the neonatal health area. So when we have a proper diagnosis and treatment in situ, we are talking about closing the gap. We say that this warranty a timely diagnosis, so it allows an early detection in the critical moment without delays for transferring that many times is difficult to realize, to carry out. It allows to improve coordination between the different professionals, remove the risk associated to the transport of critical neonat, and reduce stress of recently born families that has an impact on the future of this population. So since we have started our work, we have been able that out of 57% of recently born that had diagnosis and treatment on site. Now in 2024, we are in 94%. These networks of diagnosis and treatment with itinerant laser allows interconsultation and professional service, but also has improved the access to specialized care, leading or carrying the diagnosis and treatment to the areas or to the health centers where the patients are located. And this has improved the neonatal health. What are the pending challenges? Stable funding. We haven't received a lot of funding in the last years, but we urgently need resources to guarantee sustainability and extension of the program for the long term. Nowadays, there is still inequity in the access, continuous of geographic gaps. So there are still these geographic gaps and socioeconomical gaps that limit the access to balancing an equitative and quality health service. We need to assess the opportunities lost. The unusual cases should not exist, and the lost opportunities of diagnosis and treatment should not exist. That's why we need a renew institutional commitment, creative funding mechanisms, and policies that make effectively access to the universal care of the health. Conclusions. The ROP, it's a model for safety of the patient. It's a key indicator for patient safety. It reflects the comprehensive quality of the perinatal care. We say perinatal because more and more the obstetrics has a prevention role in the rhinopathy, and not just because of the pulmonary maturation that in our country is not more than 50%. So it's a big step that we have, those that we work on the perinatal care. So because we identify every time more maternal risk factors associated to ROP. Alejandro, 1 minute. Yes. Multidisciplinary approach. It requires a synergic and multidisciplinary approach, integrating all the perinatal care and a strategic investment in ROP that is cost-effective and give quality. And the ROP programs shows that the systematic collaboration and the professional commitment can transform the health outputs at national level. Thank you so much. Excellent, excellent experience. Thank you so much, Alejandro Diners, for the presentation. And now we give the floor to Malone Timothy from Trinidad and Tobago, who will share his country experience regarding prevention and dealing with this kind of disease. To you, the floor.
Tenés que hacer clic, Alejandro, en dejar de compartir.
Alejandro, you should click on, okay. Great, thank you.
Good afternoon, everyone. Buenos tardes, boa tarde. My name is Dr. Marlon Timothy, as Pablo introduced me, and I'm very happy to be here presenting Trinidad and Tobago's experience with preventing infections. Can everybody hear me okay?
Sí, perfecto.
Excellent. All right. So for those of you who do not know Trinidad and Tobago, we're a small twin island state just at the tip of South America. As you can see, we're very close to the border. We are celebrating our Republic Day tomorrow, September 24th. We have a population of just about 1.4 million. We have the best food in the world, and we have the best carnival in the world. Sorry to the Brazilians who are on the webinar, but it's true. And we also have some of the best athletes in the world, as evidenced by the recently concluded national championships in Tokyo. So what has been our experience in trying to deal with preventing infections? And so what I'm going to take you through a very brief look at our NICU setting. And so there are currently 6 neonatal units in Trinidad and Tobago. There are 3 level 3 units in existence, and between 2014 to 2024, we added 3 level 2 units. So now we have 3 level 3 units and 3 level 2 units, one of which is in a private maternity hospital. In 2014 to 2024, we actually only had 1 neonatologist for the entire island. We now in 2025, because of training internationally, most at the University of Toronto, we now have 3 neonatologists in the public sector. In 2013, our neonatal mortality rate was about 13 per 1,000 live births. And now in 2025 to date, using our data, we now have at least 6.9 per 1,000 live births. And as we know, we have targets set by the Sustainable Health Agenda for the Americas and the Sustainable Developmental Goal targets for the Caribbean and Latin American region. We all know neonatal sepsis to be one of the biggest issues that we face in caring for these vulnerable babies in the NICU and across the Caribbean and Latin America. And we know that almost 500,000 of these babies die from sepsis, and that about 7 million cases of sepsis occur between days 0 and 60. So I'm going to share with you the trends in Trinidad and Tobago's approach to neonatal sepsis. And this is despite declining birth rates, despite declining neonatal admissions, and despite declining babies who are being born less than 1,500 grams. So the data here shows that if you look at the top line with live births, from 2023 to now, we are seeing a significant reduction in our live births in Trinidad and Tobago, and I think the same is happening across the world. Our NICU admissions are therefore being reduced, which is good, less busy for me. But in particular, our very low birth weight babies are also on the decline. And again, there's a lot of things happening in the background that help with this massive reduction. When we look at neonatal deaths, and I'm looking at those who are less than 1,500 grams, we did not have enough data to calculate for 2023, but between 2024 and 2025, we actually saw almost a 50% reduction thus far in our sepsis deaths, well, the sepsis mortality for babies who are less than 1,500 grams. When we look at the average rate of sepsis for all admissions to the NICU, we are seeing a steady decline from 2.4% in 2023 to 1.6% now. And as a percentage of our total live births, again, we're seeing a gradual reduction. Now, there are many interventions that, of course, would contribute to this reduction in sepsis throughout our entire country. Of course, maternal education, improved antenatal care, as a lot of the speakers would have spoken about. Proper use of antenatal steroids, appropriate intrapartum management, which is very important. We also started screening for Group B streptococcal infection or carriage. And of course, there's a lot of NICU environment protocols, NICU staffing protocols, nursing training, and the list goes on and on. But again, in looking at our issues with sepsis, we wanted to kind of pinpoint where can we actually make a big difference. And again, using our data and using the framework for action, the 5x7 framework from the WHO in their publication of Towards Eliminating Avoidable Harm in Healthcare, we looked at action 3.3, where it speaks to infection prevention and control and antimicrobial resistance. And so some of the strategies that we would have implemented in Trinidad and Tobago were the antibiotic stewardship program, and of course, the generation of the antibiograms, and then the central line associated bloodstream infection protocols and training. And as part of the family integrated care model, early express breast milk feeds, and of course, kangaroo mother care, in addition to the initiation of oral immune therapy in our very sick and vulnerable babies. So when it comes to antibiotic stewardship, I know it's something that we speak of very broadly. And if you are afraid to start it, I assure you it can start just as the bedside. With a multidisciplinary team, you must, I think, include your microbiologist, because the antibiogram is very, very important in creating an antibiotic stewardship program, because you must know what are the endemic bacteria of your institution and of course of the population that you're serving while you make this policy of antibiotic stewardship for the neonates. Our aim in that program is, of course, just protecting our smallest patients. And we have this mantra of the right drug, the right reason, and the right time. And that's three simple statements, but it speaks volumes to how simple and cost-effective this measure is. With our antibiotic stewardship, we start smart. So again, traditionally, when we would have trained in neonatal medicine, we would have thought about first line, second line, third line, fourth line antibiotics. And now we're kind of changing that to individualize antibiotic strategies based on the exposure, based on the risk, based on the case. So we start smart, we target narrow. If you have a mother who has a gram-negative infection, we're not going to start a broad spectrum gram-positive and gram-negative. So we'll target narrow in that neonate to target that gram-negative infection, which might be he acquired from the mother. And then we make it our best effort to stop on time. And I think this is the most critical part of antibiotic stewardship, especially for culture-negative sepsis, where antibiotics is carried on for far too long. And then you have the unexpected complication of fungal infections, which then increases the patient length of stay, increases bed utilization, staff utilization, nursing utilization, and the list goes on and on. With respect to our central lines, we discovered that about 60 to 75% of the cases being cultured in the NICU were from babies that had central lines. So we introduced, again, a set of protocols for our central lines and to prevent bloodstream infections. And again, this is a multidisciplinary team, but it doesn't just involve clinical staff, it actually involves non-clinical staff. So the stores keepers and your procurement and purchasing managers, because if you can't start such a rigid protocol for a central line to prevent central line infections without making sure that you have everything and you have it on a continuous basis. Of course, nursing training and of course, everyday evidence-based bundles for central line infection we introduced to again see a significant reduction in our sepsis. And then we incorporated the family into the NICU sepsis protocols. So of course, the early provision of breast milk and breast milk feeds, oral immune therapy, and of course, kangaroo mother care. And I will not elaborate on those because you all know the benefits of these three interventions. So I want to say thank you very much for allowing me to share those little snippets of our beautiful country, Trinidad and Tobago, and our experience in preventing infections to our vulnerable and sick neonates. Thank you, Pablo. Back to you.
Muchas gracias, Marlon, por la excelente presentación.
Thank you, Marlon, for the excellent presentation and something that really, a topic that really concerns many countries, many health centers, and many units of neonatal care. And to close this panel, we will give the floor to Cara Gilardi from March of Dimes, who is going to give us the perspective from the families. To you, the floor.
Pablo, thank you. And thank you to all the speakers who've joined us today for the wonderful presentation. Marlon, that was wonderful. And I'm going to hold you to that invitation to Trinidad and Tobago, please. So again, thank you from the March of Dimes for including us in their presentation. We'd like to share with you, and my colleague, Marcella Ehart, is going to be advancing our slides. So we'll please continue. So where you may not know it, that all of us sorry, just going a little fast. There we go. Next one, please. Perfect. Thank you. So where you may not know this, but every one of us has been supported by the March of Dimes, that if you have had or are also helping to provide screening at birth or received a polio vaccine or paid family leave, you're a part of the March of Dimes. So on behalf of all of us, welcome. And again, since 1938, the March of Dimes has been a very aggressive advocate in our country for access to care, patient safety, and the care for both mothers and families and babies. But please continue. So our legacy, many of you may know of the March of Dimes because of our work on vaccines. That is certainly an important topic today in our country, and we continued our work in advocacy. But also, I just want to highlight that we have recently launched our mom and baby mobile health centers back in 2007, but are continuing to grow those as a way to really help directly affect access. Please continue. And again, our mission is to lead the fight for the health of all moms and babies. And will please continue. And the reason for that is due to the very challenging issues facing so many of us across the world and certainly in our country. We'll stay here for a second on the slide that unfortunately the United States remains among the most dangerous of developed nations for childbirth. And you can see many of these statistics here that unfortunately, I'm sure are not surprising to any of you. But with 5.5 million women living in areas with low access to maternity care, that has been an increasingly critical issue for our country to make sure that at the most basic level that women and families and children are even able to access care so that so much of the good work that many of you have already presented today can even take place. You can also see about, oh, thank you. So in that previous slide, it does also just talk through about the certainly the disparity in both geography and then the disparity as well in terms of racial and ethnic outcomes for both Black and white mothers. So thanks. We'll continue, please, Marcella. Thank you. So I do want to hold on this for 1 second, and there is a QR code, and I'm also happy to share this, Pablo, with you if others are interested. But the QR code will bring you to the 2024 Maternity Care Desert Report put out by the March of Dimes that really dives into this issue of access in maternity care deserts, where there is a lack of both either maternity care resource, no hospital or birth centers, and the ability to even provide obstetric care or have access to a provider. So that report, the most current one, is from 2024, and we do plan to produce another one in 2026. So, but if you are interested, please take advantage of that information. So we'll continue. Our strategy, as you can see here, as an organization and a nonprofit organization, non-government organization, is to really address preventable maternal and infant mortality and morbidity across the whole pregnancy journey. So antepartum, labor and delivery, postpartum, and NICU. I'm going to spend a few minutes to speak about the role of our NICU Family Support Program next, but I just do want you to focus on the fact that the March of Dimes is a place where you can come and receive information and support on improving access to care. specifically our low-dose aspirin campaign that's helping to manage hypertensive disorders of pregnancy and ultimately also reducing preterm birth. Thank you, Marcelo. So we'll continue. In my role with the March of Dimes as the Associate Vice President for NICU Family Support, I have the good fortune to support this network across our country of hospital sites and staff who are uniquely dedicated to the needs of families. So they are not there in a clinical capacity, but they are there to be dedicated to the needs of the family during their NICU stay. This program has been running for over 24 years, and next year we're excited to celebrate our 25th anniversary, and we reach annually 50,000 families across our 70 sites. The program is dedicated to three main goals, and that's to educate and support families, educate and support NICU staff, and also to improve the NICU experience. And one piece we're going to share with you today that I'm privileged to share that was wonderful work that my colleague Marcella, who's on with us today, has also been doing, is part of our patient experience work, where we've done a project called a Voice of the Patient panel, where in partnership with the hospital, we are able to really bring the families back into after they have been discharged from the NICU with their baby to be able to really share and communicate what was working for them, what was not working for them, what was helpful and what was not helpful. And we have found that this has been an incredibly effective way for hospitals to really learn from families about the impact of interventions on their child and on them as a family. So Marcella, will please continue. So we're going to show you a video in just a second, and this is, we'll hold for 1 second, please, and that this is the mother of a family that has given permission for us to share. This was just presented at Cedars-Sinai in Los Angeles, where this is a mother of a child that had whose child had extreme sensitivity when it came to commercial baby wipes in their skin. And this is just a very small glimpse of a much larger video. Of the parents' experience when it came to this issue that I think hits on a very important part of patient safety. So with that, Marcella, can you please share our video? Are you all able to hear? It looks like there might be a problem.
No, debe de compartir nuevamente con audio, por favor. You need to share again, but with audio.
Marcella, are you able to stop and reshare again? We did test this and it worked, so I'm sorry it's not working right now. Okay, Marcelo, let's move on. In the case of technical difficulties, we always have a backup, so we'll move to the just the case study. So Marcelo, if you could advance the slide just to the case study, thank you so much. So as I shared, this was a family who agreed to be interviewed and one of many on a panel who was sharing her experience that what was happening to her, that she was feeling that it was unsafe for her baby to be in their unit because there were very clear guidelines in the chart, and she mentions this in her video. And her fear was that, and I'll quote, that the chart wasn't being read, that this is a mother who knew that there was a very clear impact on her child. It was much more than just a skin rash. This was an open wound, as the mother was sharing in this video, and that she was very concerned about the safety of her child and that the role that it took on her to feel that she couldn't leave and she had other children at home. So it was just an important message from this mother about the importance of partnering with families, welcoming families into the experience of both caring for their baby during the stay and then also bringing them back after when possible to really learn from their experience and be able to add that learning into our policies and practice as providers. So with that, Marcella, I'm not sure if we're a little bit stuck here, but I did just want to also, again, thank you all for the invitation and for the opportunity to be here with you. If you are interested in more information on either a Voice of the Patient panel or on the maternity care desert report, we're happy to share that as always. And again, Pablo, deepest thanks from the March of Dimes.
Muchas gracias, Cara. Muchas gracias, March of Dimes,
Thank you so much, Cara. Thank you so much, March of Dime, for sharing the experience. And again, Karen, Carla, Marlon, Alejandro, Paola, and Aline for extraordinary presentation and experiences. We know that we have more successful experiences, and we would like this dialogue, this reflection to be repeated and reply in the working spaces, in the areas where you work, in order to achieve the goals proposed by Ernesto at the beginning of this session to become a reality in the America region. Thank you so much for all of those that have participated, more than 1,000 people connected. And to close this seminar, now I will give the floor to Ms. Sonia Cafe, who is going to give the closing remarks. And of course, thanking, in addition to the speakers and participant, the Department of the Health Service units and all the team that has participated in the communication, and also to the interpretation for the support for making this an successful seminar.
Thank you so much, Pablo, and congratulations. Pardon. Congratulations to all the participants, and thank you also sorry, to the persons who shared their comments and their contributions in the chat. We hear you, we read your contributions. Thanks to everybody. As Pablo said, a lot of information was shared, good practices, suggestions, and we hope that those will help us advance in this area. I don't want to take too much time. I just want to highlight 4 things that I think we can do moving forward that were mentioned repeatedly. First of all, the importance of data. We need to ensure that we generate or that we strengthen data systems to give us to provide the information that's needed to continuously improve our systems, our care, to prevent mortality, and to ensure that our children receive quality care and safe care. And based on the data, review protocols, review SOPs, review practices to identify again where we can improve. Sometimes big improvements, sometimes small improvements with big results. Those continuous processes of quality improvement are things that we all can do, taking into account the specific characteristics of the age groups, as we said, from the newborns to children to adolescents. And then capacity building, strengthening the capacity of care teams to provide that care consistently in line with the protocols and SOPs. And then finally, partnerships. First of all, with parents, because we need to ensure that our parents are empowered and that they have the resources they need, both within the family as in their communities, to provide the care, the continuation of care once the child has been discharged from the hospital or even during the care in the hospital. Partnerships with the parents and with the broader community, making sure that there is this multi-sectorial environment that provides the support that families need, that children need, that care teams need. And so if we can do 1 or 2 things, one step closer to improving the quality and patient safety from the beginning, then I think we have all achieved the goal of this webinar. Thank you again for your participation, and we wish you all a very good rest of your day. Thank you.
Muchas gracias nuevamente. un excelente día y tarde para todas y todos. Y con esto entonces
Thank you
damos
so
por
much.
finalizado el
Thank you.
seminario y
And
invitamos
we
a
close the
socializar
seminar
también este
here,
seminario que
and
va a
we
estar
invite
disponible en el canal YouTube de la OPS
to
para poder
socialize this
difundirlo en
seminar
sus
that will be
espacios de
available
trabajo y sus
on the
parejas.
channel
Muchas
of the
gracias y que tengan un
OPS
excelente
that
día.
so you can share it with your
Pablo,
coworkers at work.
Thank
Thank you, colleagues.
Hello.
Congratulations.
Gracias a todos,
Thank you.
Pablo.
Bye-bye.
Felicitaciones a todos. Gracias, Ernesto, Sonia. Bye bye. Thank you, Cara, Paola, Marlon, Albert. Thank you, Aline.
Gracias.
Thank you, Susana.
Un gusto.
Bye bye.
Felicitaciones. Bye bye.
Hasta luego. Gracias.